Okay.
Or do you need a minute?
No, I'm ready.
All right, let's see here. Oh, I need my little wheelie thing. There we go.
So is there a way to minimize this thing over here? Can I make this smaller?
What are you trying to call it?
Can you guys see this thing up here that's got all the controls for the?
No. It doesn't show that. We just see nice radiographs.
Okay, pretty high quality radiographs too.
Oh yeah.
Okay, so this is a guy with confirmed COVID-19 on the basis of a nasal swab, and I only have radiographs on him. He doesn't have a CT scan, but I've got an old radiograph over here on the, let's see, I think this is the, which is which now. So yeah, this is the current radiograph, and he's in the, he's in the ICU here like that, and he's got a little smudginess of his lung up here and maybe down here. But if we look back to this older radiograph, this is from January, 2 months ago, he actually looked worse there. And this guy's got some chronic condition. I think it may be chronic renal failure or something like that. I will provide details when I post this case. So this man's chest radiograph has never looked perfectly normal, at least not for several years. And his current radiograph actually doesn't look as bad as the previous one, and yet he's got COVID in his nose on the basis of a swab. So not every case has radiographic findings or radiographic worsening.
I think it's an important point, David, because at least based on what came out of China, where they were doing mass swabbing, a fair number of patients, I think it was like 40% or so, don't have chest symptoms, and they don't necessarily get imaged. So I think that's why we're seeing it popping up everywhere, because people are walking around with a runny nose. And,
right.
Of the, was it the I think 7 coronaviruses that cause human disease, 4 cause a common cold.
Yep.
And the other thing is children under 15 have not been documented to have COVID-19 pneumonia, but they don't seem to get. But I bet they're walking around with runny noses and giving it to everybody else. So
right.
So it's interesting because they've talked about the sensitivity of CT being better than PCR, but which may be true, but it depends on the pretest probability. And and I'm going to show a companion case to yours and point this out. But yeah, I would have. We looked at, well, we would have called your radiographs normal.
Yep. Right.
I would have, yeah.
Okay. So and you make a good point. The other thing is it can be in your nose on one day and not be in your nose on another day, and sometimes it can be in your lung and not in your nose. So it's a sampling problem, among other problems. Okay, and then here's another case, and here's a man with an abnormal chest radiograph, and this was back in November. This man has a traumatic brain injury. I think it was from an automobile accident, and he has chronic problems with aspiration. So back here in November, he had a lot of consolidation in his right lung base. He's got right pleural effusion or thickening. He's got some stuff in his left lower lobe as well. That's all attributable to aspiration. And then let me show you more contemporary imaging on him. Here's his current imaging from a week or so ago. And this man died. And at this point, his radiograph actually looks better. Okay, now we had a CT scan on this current admission, and it shows an abnormality here. It looks like in the upper lobe here, looks like bronchiolitis. We have all these little smudgy things centered on small airways. You can even see some air bronchiolograms, and things are worse in the more dependent parts of his right upper lobe, and then they're bad here in his lung bases here, particularly his right lung base. So this is an excellent pattern. Looks like aspiration, bronchiolitis. This does not particularly look like a viral infection. It's more localized than viral infections usually are. It's somewhat dependent on the right, and he's had aspiration issues that are very well known in the past. So there's nothing here that I would pin on COVID-19. And his nose was swabbed, and it was negative on the local test. the test was sent to the CDC and they came back and said it's positive. So here's another guy who I think died of aspiration, and or maybe he's got COVID brain disease that was making worse because he was more somnolent and everything. But he does not have a disease in his lung that I would pin on COVID. Okay, so
yeah,
just
that pattern has not been reported at all in the hundreds and hundreds of cases. I'm on board with you there. I think
no nodules, right? Okay, so just because you've got COVID doesn't mean you can't aspirate, and it doesn't mean you can't have a normal chest radiograph. Now, there was one case last night that was admitted, and the test is pending, and it really looks like COVID. But I don't want to show that until it's documented. So I'll check in the next few minutes to see if the test has come back yet. But that case really looks like COVID. But I don't want to create the wrong impression by what's it called? Confirmation bias. So, well, I'll hold off on that case. But we've got, as you've heard, we've got a lot of cases up here, and there are 21 people, I think, pending testing right now in this institution. So it's definitely here in Seattle. It has emerged.
All right.
Okay.
Who wants to go next?
I've got two quick cases.
All right. No.
I'll just minimize that. This is a case, a couple of months back, I showed a rather impressive case of an acquired transcostal herniation of lung in the context of a coughing spell. And this one is even more impressive than that one. So let me show you the coronal. And let me get the comparison in the right place and get things ordered here for you. So we have, let me get my timing right. We do have a comparison. These are from the outside from last year. And now I need to, yep, from May. I'm not sure why the CT in May was done, but you'll see the changes are pretty remarkable. So the history seems pretty clear-cut. He reported an episode of severe coughing, I don't know why, and associated with that, very sudden and described as severe right chest pain with that episode. So if we go here at this level, and let me just go to about the right level here. I'll go to the lung window to show you the herniation there of lung into the chest wall. And that's clearly new from before. And then going back to the mediastinal window, you can begin to appreciate how separated these ribs are. And indeed, even the liver is protruding laterally quite substantially, new from before. And I also found a fracture, which is where did I find that? Let me make sure I got my dates right here. There is a fracture. I'm trying to, oh, there it is, right there. I think that's the fracture I saw, which I thought was new from before. Let me just look at another image I thought showed that better, I thought. Can't find it at the moment, but a good one. But you can see the change in the appearance of the liver. So I think looking at the ribs here, they're really spread apart. And where was the one image where you could see in relation to the chest wall, particularly, yeah, you can see the shredded muscle, right? The intercostal muscle is gone there, and there's just little tags of it in that location. Knew from before. So acute acquired transcostal herniation of the lung with disruption of muscle. And I saw this in the context of being fixed today. So this was last year, but it's being repaired today. Just sutured up. All right. Next one is just a nice classic case of rheumatoid nodules. In a patient with long-standing rheumatoid arthritis, a lady. And on some of the radiographs, these are hard to see, but there's a nodule here, and there was another one somewhere else. I can't quite remember. So that's from December of last year. But the nodules we see here on the CT are super classic. So the ones that are circumscribed, smooth margins or lobulated margins, often subpleural. You'll see some that have cavities in them, like that one where the cavity is kind of strange, little nodules protruding to the cavity. Additional ones there. Here's another cavitary one. Here's a bigger nodule here. This actually resolved, so that isn't a rheumatoid nodules, but the others are pretty typical in this context for rheumatoid nodules. Really no differential diagnosis for those if the patient doesn't have any reason to think there's some infection, for example, like an opportunistic pneumonia. Does everyone agree? I think these are super typical for rheumatoid nodules.
I was going to ask, does anyone know why they have a predilection for the subpleural lung?
Oh, I don't. No, these are particularly
the ones I've seen too. They often are, they tend to be close to the pleura, or like, I mean, all of yours almost are along the pleural surface. I just don't know if anybody knew why. Because I don't have, I don't know.
I don't know. It's very distinctive. Definitely subpleural.
Okay.
All right.
Thanks.
Typical rheumatoid nodules. Those are my two for today.
All right. Anybody else got some cases?
I got cases if you want them.
All right.
Yeah. All right. This is a case we just had this morning. It's actually a repeat follow-up. So this is a patient who came in with a pretty evident large mass here surrounding the left atrium. Come on, keep playing. There we go. You can see that, interestingly, even though it's around the pulmonary veins aren't occluded, which is interesting. There's a large portion that's surrounding the left atrium. There's also a portion within the left atrium. And if anyone wants to know what real first pass perfusion looks like, so here's, basically before just starting to give contrast, and this thing just lights up like a light bulb. Here is the T1. Here's the T1 post. You can see this is a very nasty tumor. So we've been following this thing for a little bit. The patient actually had a percutaneous biopsy which showed myxoma. And then they went for a partial resection debulking, which also showed myxoma. And I'm like, there's no way. I mean, not in a million years is this even could even theoretically be a myxoma. I'm like, you need to send the path elsewhere. And this was done from an outside hospital, I think. And she was coming here, but they kept calling her myxoma. And they finally sent the path to Mayo, and it came back as what you would expect, a sarcoma. And the question is, what kind of sarcoma? This was a fibrous sarcoma. And you can always wonder, is it primarily mediastinal / pericardial invading in, or is it left atrium invading out? It's really hard to tell, but this is and this thing is really, it's amazing how much this has grown. Our last study was like 2 months ago. And this thing is just blown up in that short period of time. And that was even after a debulking procedure. So fibrous sarcomas, I mean, there's no real way to differentiate them. I mean, had calcification, you could say, oh, it's a osteosarcoma. You don't really get liposarcomas of the left atrium. And fibrous sarcomas are actually one of the rarer types of left atrial sarcoma, but this is just a cardiac fibrous sarcoma. And then this, let me separate these by, make sure which case, I don't remember which case this is, 1 second. Oh, this has to be set up in the right time frame. Let's see here. Okay, so here's 2000. So here's a guy actually presents to Travis's old haunts, comes in with this thing filling the main PA, kind of getting to the left PA, definitely chronic disease distal to it. And to me, this looks like, without a doubt, a sarcoma. It grew despite anticoagulation. It was PET negative, but interestingly, they took it out. This was at Emory. They actually did a resection, and it came back all as clot. So the reason we saw them, so after, you can still see, there's still some chronic disease in the segmental area. So he came back. So he presented about 6 months later, and you can see he's got acute PE here, and then has this thing growing again. And eventually we see him. And I mean, I've never seen clot look like sarcoma so much in my life. So here it is, filling the main PA and the left PA, and it had continued to grow. He was still on high dose anticoagulation. You know, again, he had a resection of this previously, and it showed all clot. And I was like, they must have missed sarcoma, you know, because a lot of these sarcomas are covered by clot. Anyways, he died waiting for surgery, and it was all clot. And I mean, we see a lot of cases sent here that are, you know, you're like, how did anyone just call this CTEPH? Clearly it's sarcoma. I just never seen a case that really should be a sarcoma, but just turned out to be thrombus. And we get a lot of mimics, but I've never seen a mimic look like, even getting CTEPH in the main PA is we see it all the time, obviously in the left and right, but have one extending to the valve, to the near level of the valve is, it's just, of the 600-700 cases I've looked at now, I've not seen that, and they hadn't seen that either.
So this is pseudo CTEPH?
No, it was CTEPH. Pseudosarcoma CTEPH.
Pseudo CTEPH.
Yes.
Get you back to CTEPH.
Two wrongs make a right. Yeah. And you can see the right heart. And the last case, I don't know if I showed this, but what I like about this is, and I think I showed a different case and we had a discussion. So I'll take a poll here. So this was sent to us. Patient is a young patient, I don't know how old, 30s, 40s, coming in. I don't have to tell you, there's clear signs of pulmonary hypertension even on this non-contrast, massive PA, huge right heart, huge right atrium. Some septal thickening, some of these kind of ground glassy things. So the question is, you know, who thinks this is just PAH and who thinks this is PCH PVOD?
It looks like the latter.
The latter I would go for PVOD/PCH.
You've got the effusion, you've got a small left atrium.
I've been fooled so many times. I'm just going to go with either. I don't know.
Both simultaneously, both present in the line.
Well, they're both type 1 and it doesn't really matter. But so I thought this was going to be just PAH. I didn't love it for PCH. I mean, I understand the effusions and the septal thickening. Just this degree of these, you know, I've seen enough cases of PCH here, just seeing this degree of the central lobular nodularity kind of stuff. And it really is in the upper lobes, the lower lobes a little spared. Anyways, I had a bet with my pulmonologist. We bet a cookie on it. And because she got an explant. And the other question is, so she got a transplant. The question is, what do these areas, and we talked about it 100 times, and Dave says they're plexiform lesions. And unfortunately, I don't have a good answer here. Here is the upper lobes showing the these areas of arch. What she did notice is that in the upper lobes surrounding the arteries, which are dramatically abnormal. There was a lot of like hemosiderin-laden macrophages from hemorrhage, but there wasn't a lot of plexiform lesions. So I know, Dave, you said that you have a case where you show it's all related to plexiform lesions. Here, there weren't many. There were just a lot of these around, even the very, very, very small vessels, a lot of these macrophages, presumably due to blood, hemosiderin-laden, not from smoking. She was a non-smoker. In the alveoli directly surrounding these very abnormal arterials. Anyways, they did all the staining. Here is the lower lobe where, again, you see these to a lesser extent, but look at all these macrophages around the arterial. So I don't know what it is. I don't know if it has anything to do with these macrophages around that, but they're really pronounced surrounding just the arteries. I guess they're cleaning up the areas where blood somehow, either from increased pressures, I'm not even sure, I don't even want to speculate why there's so much peri-arteriolar hemorrhage in these patients. I'm sure someone knows. But there was no PCH or PVOD in this case. We see a lot of that here. I think our pathologists are quite good. They did all the stainings for it. And it was just PAH, and maybe the cause may be due to peri-arteriolar hemorrhage with increased kind of lipid or hemosiderin-laden macrophages, like you see with, very different from RB, but you get different macrophages, filled with other material. I don't know, but just kind of an interesting path correlation. And we went back and looked at a couple cases, and in these couple cases did see a fair amount of these hemosiderin-laden macrophages directly around the pulmonary arterioles in these patients with PAH.
Got it.
In the upper lobes, most pronounced in the upper lobes. So I don't know, but I thought it was just a nice example. And I get a cookie, so I'm more excited.
Nice.
About it. Yes.
Yeah, I mean, yeah, I would have said PVOD too, except we've had a couple that look just like this, and then they say, nope, no PVOD, just PAH.
Yep. And the PCH/PVOD cases I've seen don't have this degree of nodules, and the ones I've seen, the nodules tend to be a little bit lower lobe predominant, whereas these tend to be upper lobe predominant. But so this was to me a flip of the coin. But those are my cases.
Yeah.
All right.
I think we ought to add as a third possibility that we're just seeing the result of some bleeding into the lung and some maybe some macrophages and maybe even eventually some fibrosis trying to clean up the blood.
Yeah.
It looked like on that first slide you showed there was some collagen around one of those vessels. But yeah.
I could pull it back up real quick. So here's all the slides I have. So here's the H&E. So here's the airway. Here's the vessels.
Maybe it was the higher power one.
And then here, this is the higher power one. Oop, that's a small little.
Yeah, well, right there. See that pink stuff? Just outside the wall, sort of right in the middle. Yeah, that looks like collagen. Just not the denser stuff, but that looser stuff. Just.
So I asked her what this stuff was.
What is all that?
She said you commonly see that in it's like some adventitial abnormality you see. I'll actually ask her.
Yeah, it looks like collagen, doesn't it?
It does. It looks like it to me. I mean, but honestly,
but
I'll actually send her an email and ask what this stuff is surrounding the vessels, because she was saying, it's probably just the pronounced thickening of the vessels. And I said, well, we tend to. I said, I don't know. We tend to see this abnormality more in the upper lobes. And then she went back and looked and saw that these macrophages were definitely more pronounced in the upper lobes. So
that's neat. Okay.
Yeah.
Well, thanks.
I wonder if it's so okay, let us know. I mean, you may be seeing the lesion right here. I mean, that pink stuff may be the ground glass stuff on CT.
Maybe 100%. This is just maybe vascular wall thickening. And I have some other cases, I have to find it, where there's just the most dramatic ground glass. Literally, if you do an MPR just along the vessel, it's like it is really striking.
See, that too looks like collagen, sort of like at 11:30. All that.
I mean, all this stuff looks like.
Yeah.
It is all this stuff. Yeah.
All right. Excellent. All right. See, Travis or Peter.
Okay, I can show a couple. This is for Howard. I just saw this yesterday. And this is a 40-year-old, as you can see, who has cancer and is undergoing follow-up imaging. You can see there's big, bulky, heterogeneously enhancing mediastinal nodes here. And she has all these little discrete cysts and a few small little nodules. The solid nodules, some of them look like intrapulmonary lymph nodes, but a lot have gotten smaller with treatment. Like that one doesn't look as much like an intrapulmonary lymph node. And so this is, she's had 4 or 5 CTs in the last year, and every single one of them, the nodules have been getting smaller, and then people have just been saying, well, the cysts are probably treated nodules that have left behind cysts. And knowing the type of cancer she had, I went back and looked at the original study, and this is her original neck CT from just over a year ago. And you can see these cysts are already there, and the nodules are bigger. And of course, Howard, I know you're wondering what the primary is. And you can see it's up here, specifically what type of thyroid?
Oh my goodness. It's one of these calcitonin or thyroglobulin producing medullaries.
Yeah. Yeah, so this is medullary thyroid cancer, exactly. And so I think that these are probably cysts related to calcitonin deposition in the lung as a manifestation of amyloid. And the cysts are similar, you know, maybe they've gotten a little bit worse, I don't know. But the point is that they've been there, you know, since before her treatment was instituted. So it's not that the cysts are treated in metastases that have just left behind holes. And so this is her chart, and this was her baseline calcitonin. It's funny, the normal range is 5, hers was 35,000. And I think it's, you know, they say greater than 100 may occur, you know, if it's provocative testing is suggested if it's not clearly diagnostic. I would say this is clearly diagnostic, not knowing anything more. But her calcitonin's been elevated since then. I don't know the time course of this because this was, like I said, at the time of diagnosis. I don't know how long it takes for the calcitonin and the protein to deposit and cause the cyst, but I think that's probably what this is. Sure, could she have LAM? Maybe, but I doubt it. And this was the article you had sent way back when, just talking about amyloid association being a result of calcitonin deposition. You agree?
Yep, definitely. I think that the other case that we saw was also your case a couple of years back. We had a patient with a similar
it was one from memory. It's been years.
Yes, years back.
So have you had one too? Because I know you brought it up in other times, I thought. Okay.
No, I don't personally have a case of that. I have one, a radiograph that I have from many, many years ago, in which the protein, because I don't have a CT, but I have a radiograph in which a patient with medullary cancer had multiple nodules, some of which are either calcified or ossified on a chest radiograph with the medullary cancer. But of course, I don't know if there were cysts because we didn't have a CT.
There are no calcified nodules here, and these are small, so it's still a presumptive diagnosis, but I think it certainly fits more than treated metastases since it was before treatment. So I think it's just important for people to think about in the setting of medullary thyroid that produces calcitonin. All right, now this one, I posed this question to Seth the other day. I don't think I shared the images. This is a case of another young guy who came in just after the new year. And this is an abdomen and pelvis CT, and he had right upper quadrant pain. Nothing really in the abdomen, but they noted this thing that's intermediate attenuation. It's like 50, somewhere around 50, 60 Hounsfield units, and raised the possibility of this being some sort of hemorrhagic or infected. Well, they just said it might be a pericardial cyst. It was actually when I reviewed it later that I was wondering, could it be hemorrhagic or infected? They did a follow-up study later that day, like 6 hours later, or actually, no, that's 9 p.m. So it was 16 hours later or something. And you can see now that this thing has enlarged over the course of just a few hours. And it looks like it has a little bit more of a discernible wall here, and there's a little bit of surrounding atelectasis, maybe a little bit of inflammation, as well as a small reactive effusion. So he kind of had a borderline white count. He is actually having shoulder pain, probably just diaphragmatic irritation radiating. And so the question I posed to Seth was, have you ever seen an infected pericardial cyst? I was wondering if that was what it was going to be. And I showed this, talked to a couple of other people and the surgeon. We found a couple of isolated case reports of an infected pericardial cyst. And I thought maybe it could have been hemorrhagic too, but he did have fever. So they gave my...
sorry, I just saw a case from the ARP submitted that was a lymphangioma that got infected, which I had never seen before.
Right, so some sort of mesothelial cyst or something, right? Something like in this area. Well, got fooled.
What happened in the left lower? What's happening down?
He may have aspirated a little in the hospital.
Okay.
That was acute.
Okay.
Yeah, but so he was on antibiotics, got better, cooled off, and then came back. This was at that time. You can just see the classic right cardiophrenic angle lesion. Came back last month and got this taken out, and the surgeon said it was all like paste inside. It wasn't really a cyst. And this is a very long-winded discussion from our pathologist, but he thinks it probably is a torsed and necrotic solitary fibrous tumor.
What?
There was some STAT6 positivity. So I talked to him on the phone because I was giving him a little bit of shit for such a long-winded and hedgy report, but he thinks that's probably what it is.
Really?
Yeah.
So did he think it was does he think it was infarcting at this time? The initial
probably.
Scan?
Yeah. Well, because these scans were less than 24 hours apart, and the guy came in with relatively acute onset of pain. That's why he got the abdomen pelvis CT, but it makes sense. It was right upper quadrant, so it could localize there, and then it spread to his shoulder. But yeah, that surprised me.
So Travis, it looks like the timing may be a little different in the contrast, but the mass looks much lower attenuation on the later CT.
Yeah, I don't know if some of that. Oops.
Yeah,
some of that's a little streak. I know. That's why
was there progressive necrosis?
Yeah, I mean, it's kind of heterogeneous, but it's maybe a little bit of noise. But it just, I was kind of like Seth showing that one. It's mean of 41, and this is a little bit later, and mean of 40. So it's not even. Yeah, that's why I was pretty convinced this was going to be, the third case report we could put out there of an infected pericardial cyst based on the location.
If it were a high attenuation mass with some mass effect, you would have said, yeah, it looks like a fibrous tumor.
Yeah.
That's pretty cool.
So
we'll do around two if we can.
I'll stop there, Jeff.
Thanks.
All right. Peter, you have cases?
Yeah, I got a few.
All right.
So I think Howard showed a case of this a couple months back. I think you guys have seen other cases of it, but thought it was a good example. So this is a young patient, mid-30s, normal, no past medical history, normal health up until about the fall. In October, he started getting ulcerated skin lesions, really painful, multiple places, including both hands. And so here is his MR of his hands. And on the right, we have the proton density FATSAT images. And on the left is the T1. And so on the proton density on the right side, you can see at the proximal interphalangeal joints, there's this soft tissue swelling, edema. There's marrow, edema signal in the marrow. And then the T1, you can see there's lost dropout of signal. So there's osteomyelitis here. So associated with these skin ulcerations, at least on the 5th digit. But at the same time, the patient also started getting progressively short of breath. So here is his first CT. So looks kind of peribronchiovascular consolidation. There's some subpleural sparing. Clinically, pneumonia, infectious pneumonia didn't make sense. So this looks like organizing pneumonia, possibly some alveolar damage. Yet there's not much in the way of fibrosis. There's not significant architectural distortion or traction bronchiectasis. And this was biopsied and it was confirmed. It was at an outside place and it was confirmed as organizing pneumonia histology. But unfortunately, he started his lungs got much worse over the next month. So this is a follow-up. I think this is just a few weeks later, and you can see increased. So now there's a pneumomediastinum, there's small pneumothorax on the right, architectural distortion, there's basically fibrotic changes. So this is kind of the diffuse alveolar damage, organizing phase, probably some Macklin effect here. And this is his most recent. There's another interim CT here, but so basically the combination was the raised concern for provisional diagnosis was made for dermatomyositis, the amyopathic form, because he didn't present with weakness, and so this was sent out for MDA5 and they came back positive. So this is just another example of MDA5 variant of dermatomyositis. And this is his most recent CT from a few weeks ago, and he ended up dying.
Usually you see this in females, so this is a guy.
Yeah,
that's amazing.
Did they do an autopsy?
I'm actually not sure. He just died, so I haven't followed up what's happening.
It'd be really interesting to see what the lungs look like now from an open lung biopsy of OP to what it is now, which is probably DAD and fibrosis. That you don't get past at 2 points in time, rarely ever. So it'll be interesting.
I'll look into it. Yeah.
Wow, that's traumatic. Yeah, it's very similar to the one I recall now.
Yeah, yeah.
My patient also had acrolysis and lost digits. Yeah.
Yeah, and it seemed like it came out of nowhere. The skin lesions is what presented first. Right. Not much weakness.
Rapidly progressive. He ended up on a ventilator and veno-venous ECMO in a very short period of time.
Yeah. I actually recently just rewatched your case just because I remembered you presented it. It was pretty similar. This is a case we just had of a patient. This is just a coronary CTA. It was just for shortness of breath, maybe some chest pain. But anyway, there isn't much in the way of atherosclerotic disease. But the thing that stands out is this very dilated RCA. And if you follow it, as you would expect, there's a fistula. But this one is fistulizing, so follow this branch, it comes off the RCA. This one is fistulizing with the superior vena cava right there, which I've seen several of them with the coronary. They go behind and go to the coronary sinus, but I hadn't seen the fistula of the SVC. And you could also see there's some degree of, so this is imaged in diastole. You can tell by the open mitral valve, and you can see there's diastolic flattening of the septum here. So there's volume overload from the shunt of the right ventricle.
Can you scroll back up? Was it into the right atrium or the SVC? Can you?
It looks like it's to the. It looks like it's the low point of the SVC to me.
Right. Yeah. Okay.
Let's see, right there. Let me see where it was exactly.
Yeah.
So,
No, you can see it. It's
right there. Right there is where
there may be another entry point lower down. You scroll.
Yeah, I can try. Yeah.
I was wondering, right?
This is lower down.
Right there.
I think this is a appendage. This looks like it's part of the an appendage to me. Doesn't look like it's connected to that vessel. And the vessel is right there.
No.
And the so if you follow the rest of the RCA down, it looks like it's more normal caliber as it goes underneath. So it's just a branch of the RCA that is fistulized there, and I'm not sure what they're going to do. They should potentially be able to coil that, because I don't think there's that much supply that would be compromised if they did. But I guess that would depend on how much they're overloading their RV.
RCA to, wow,
RCA to SVC.
can't remember if I've ever seen that before. I don't think so.
And then one last one. This is a patient, I think young to middle-aged, but 1 week of fevers, myalgia. So this is chest radiograph, some consolidation here, lateral, I'll show the CT. So this case was shown to me by one of the pulmonologists that went and saw him. We didn't read his chest CT. So it's basically peripheral ground glass. So to me, this looks like an organizing pneumonia pattern. I mean, there's subpleural sparing. There's some a little bit of architectural distortion there, some organization, kind of a reverse halo sign. But the patient's presenting with flu-like symptoms. So in the setting of an infection, organizing pneumonia, lung injury. So there was some concern, but clinically the ID saw him, and clinically they didn't think he had basically enough exposure to sick contacts or traveling. So they didn't think he was really high risk, and it came back negative. I thought it was similar to some of the examples that have been shown. Came back negative for coronavirus.
It looks exactly like what's been published. That's an
right.
important point. It's indistinguishable from many things.
Right.
Although we now know the travel history and exposures and context doesn't always work with the cases.
Yeah, it was a little contradictory because this gentleman was a chef at a local restaurant, and it said in the note it said some of the people in his restaurant had fevers, but then they also thought it wasn't. They said no sick contacts.
Did they ever figure out what it was? Did they do like a respiratory virus panel, or
all the viruses came back negative?
Maybe
he just got discharged. I think he got discharged yesterday, but he came in very recently.
Okay.
He vaping, huh?
Eosinophilia or anything, did he?
Sorry, I missed that, David. I didn't hear.
Did he have eosinophilia? Because this would be a great.
Actually, no, I don't think I didn't see it. No,
Not
he didn't have a white count. Also, no white count.
And not an asthmatic.
No past medical history. Well, maybe some other viral pneumonia, but I'm not sure. Maybe it wasn't even an infection. But
Did they think about vaping associated lung injury?
Not sure, actually. I thought about that this morning, actually, that might, but I actually didn't see that in the history anywhere, and I didn't get a chance to ask them specifically.
There really haven't been many new cases of the vaping. There's been like one or two, I think, but in the last few months. I know, talking to our health department, they haven't seen a case in over 2 months.
Mm-hmm. Yeah.
Whatever.
We only have one.
Vaping is not out there anymore.
Mm-hmm. Yeah, so as of right now, we only have 1 or 2 cases of confirmed coronavirus here in Atlanta. But this was not one.
All right.
All right, thanks, guys.
Yeah, okay.
Thank you.
Okay, so let me start with let's start with this case first. So this was another case that was sent to me from our friend in Greece, and this is just a beautiful example. I'll show some images. So this patient was from Eastern Europe. I can't remember which country, but has lungs that look like this, and you can see there's cavity, and then there's this thickening along the bronchovascular bundles, sort of with these coalescent nodules, ground glass opacities. You can almost see like a reversed halo, but these are a little different, and they have nodules around them. You can see sort of upper zone predominant. So, you know, if we saw this here, what would you guys think about if we, in the U.S., if we saw a case like this?
Sarcoidosis.
Yes, that's what I would say too. And this is not sarcoidosis. This is culture-proven tuberculosis. And this is, I think, one of the best examples I've ever seen of the fairy ring sign, which is an old sign. It was described. I actually pulled the paper somewhere. I don't know if it's in this. I don't have it in this. I have it, but not in here. Oh, she was from the country of Georgia. 26-year-old female, progressive fatigue and cough, and yeah. So this was his thoughts. It was trying to explain this, but the fairy ring sign to me is a reversed halo sign with nodules. And I think when you see that, you should think of granulomatous type processes, and that's why I think we all thought sarcoid, but he was wondering if the bacillus gains entry into the lymphatics, and that's why you see the granulomas forming in the lymphatics in this perilymphatic distribution, and favors it being a primary case. But just curious what we thought about it. And there is an old case report. I want to say it's from the late 90s in Chest that talks about the fairy ring sign as a manifestation of TB.
Oh.
It's really pretty. Unfortunately, it's not a chest radiograph, but here's the coronal right there. Because yeah, you got a cavity and you got these beautiful signs here. So I liked that one. I'll send it along with the case report. I'm going to go ahead and show this case while we're on the topic. So this is a young patient that came in with fever, cough, myalgias. And this is her only chest radiograph. There wasn't a comparison, but it's abnormal. You can see there's some ill-defined opacities in both lungs. Just the vessels aren't quite well defined. Lateral shows a little bit of a spine sign there. And I don't know if that's motion or if there's truly something there. So for whatever reason, a CT was done. It sounds like a flu-like illness, and we see this. So these are sort of nodules of ground glass opacity along the vessels and bronchovascular bundles, bilateral. Some are smaller, but another good look for sort of an organizing pneumonia, but you'll see there are smaller nodules. So when I see that, I really think about infection, and in the right place, this would be a great look for COVID-19. There's been cases, several of the publications from China show these discrete nodules early on, but it's not. It's a swab positive influenza A. And we've talked about this. I'm stressing this point that it's indistinguishable, and that's there's been some articles talking about using CT potentially as a screen, because there have been a couple papers showing that patients had abnormal CTs before their PCRs converted. The problem is we have high rates of flu here, at least in the Midwest. I'm sure everyone in the U.S. does. So you're still more likely to encounter influenza, and so if we're screening people with CT, we're going to pick up a lot of influenza.
Yeah, and also, how practical is that? I mean, our scanners are shut down for 2 hours if they suspect a case.
Exactly. I mean, I think it's a clinical.
It makes no sense to me.
And that's what they did in China. Finally, they were using, but they went to a clinical diagnosis. I think you use a radiograph, and if it's normal, it still doesn't rule it out. But in someone with a viral-like illness and an abnormal radiograph, this CT doesn't add anything in this particular case. It's just made for a nice teaching case. But it doesn't change how you interpret the clinical setting. But I don't know why they did that for whatever reason. But yeah, that's one example. Now here's another infection. This is a different infection, but there are cases of COVID-19 also published like this. So this patient was a lot sicker, was in the hospital, had a central line in, and then sort of this diffuse lung abnormality on both sides. You can imagine the CT is going to show a lot of ground glass opacity. And indeed, we see a lot more confluent stuff. And all we're seeing is the affected lung injury. I mean, there's a reversed halo right there. not the best one. You got spared lobules, so it kind of looks like an organizing pneumonia, maybe some DAD type pattern, and then had a little effusion to go with it. And this is not COVID-19, nor is this influenza, but rather this is human metapneumovirus.
Right.
And so, these viral infections, and there was that really nice paper that talked about, imaging. It was in Radiographics, and I can't remember how old it is. It's not that old. Talked about imaging findings of different viral infections, and they can trend to do different things. Like, for example, RSV. I don't have the case this week, but I saw a case that showed more of a bronchiolitis. But if you look at the publications on MERS and SARS, they look just like this. They look just like COVID-19. So it's just the pattern of injury. And at this time of year, I don't think we're going to be doing any service trying to distinguish them. But this is all human metapneumovirus.
I think the comment earlier about how none of these cases seem to have central, or like tree and bud or central lobular nodules is really the only thing that distinguishes it from other viral infections that we've seen.
Right.
I don't remember a radiographics one, but Thomas Franquet wrote a nice review that was in Radiology in, I think, 2010.
Maybe that's it. I knew it was one of the
thinking about.
Yeah. And I think with the and that's a good point, Travis, because I mean, there's now been multiple case series and no one's reported those findings. Pleural effusion is uncommon. Lymph node enlargement's uncommon. Large mass-like consolidation in a single lobe. I mean, people isn't a presentation of it either. People have reported solitary lesions, but that's very limited, mild subclinical disease, and sometimes it does progress. But no one's shown like a mass-like consolidation that you're going to pick up on a radiograph. So I think if you see that, so I think there may be cases of co-infection, given that this is trickling around the community. People are going to be swab positive, maybe like David's case, where you had what clearly looks like aspiration, and just happened to be probably walking around with COVID-19 on top of it. And so I think people need to keep that in mind as well. All right, and then this last case is another infection. I decided to do all infections today, but it's a totally different one. No more viruses, I promise. But I like this case, and I think you guys will too. So this is a young woman who was treated for community-acquired bacterial pneumonia on multiple occasions and didn't really get well, and sort of didn't follow up much with medical care and hadn't had any regular medical care, and then was sent down here with this CT attached to her. And I'm going to show, we see this area of these sort of, I can't remember. I don't think I showed this case, but maybe I did. These mass-like areas of consolidation in the lower lobes, and then this denser area in the right lung, and just tiny little effusion, if even at all, and then some mild lymph node enlargement. And then what else is kind of cool, they did this very narrow field of view, but you can see she's got a mass in her chest wall there, and then another one down here, and then another one down here. And then she had a neck CT as well, because they had some palpable masses, and you can see she actually had cutaneous lesions, and you can see them better just because it's less noisy, but these are actually cutaneous, like pustular lesions. And then you'll see some in the upper chest as well, and all these skin lesions here. So they actually sampled one of these skin lesions, and this all had fungus in it. This is all blastomycosis.
What?
Yep.
So Jeff, this violates what Jeff Caney says, which is that you don't get lymphadenopathy with blasto.
There's an asterisk by that says usually. But it's pretty modest, David. For the degree of consolidation, that's just, this is a pretty bad case, and maybe it's because of this paraspinal lesion as well. I don't remember. But yeah, you're right. That's one of the things I always said. But, typically with a bacterial infection like this, you'd expect to see more pleural effusion. She's just got this sliver. But the cutaneous lesions are actually, I think, what's helpful, because when I was called about this case, they were concerned. When she was transferred, everyone was concerned about tuberculosis. Yeah. Being in Wisconsin, blastomycosis. So even this, this has been brewing for 3 months probably, because of course it's it's the end of winter here, and most of the blasto comes in when people are outdoors and it's wet, not frozen. So she probably got infected back in the late fall, and it kind of smoldered around, and then she got some symptoms and got antibiotics, which of course don't work, and then had all these skin lesions. But it likes skin. I couldn't find any bone lesions. Her brain was okay. It likes brain as well, but This is the first time I've seen visible skin lesions on a CT.
You know, Jeff, it's famous for the long latency.
Yep.
So you pointed that out too. I mean, sometimes the lesions, as you pointed out, emerge 3 and 4 months later.
Yep. It just kind of smolders. So if you, if you see big masses, it's also not COVID-19. All right, guys. Well, those of you going to STR, I'll see you there. Safe travels, and everyone else stay well.
You too.
Well, I'm back next Thursday, so I'm holding a conference.
Okay, avoid air travel, but have a good trip.
We'll take Route 66.
Greyhound.
St. Louis.
Thanks, guys. Take care.
Bye-bye.